Hi, I'm Dr. Sham, and this lecture is going to be about the hypercalcemia. We know that the hyper means increase, and the cal is calcium, and emia means in the blood. So this is increased calcium in our blood. Let's talk about the physiology. We know that the calcium is absorbed from the gut into our blood, okay, and then it is excreted by the kidneys. This is the normal mechanism. 99% of our calcium we know that is in our bones, and while the rest 1% of the calcium that is in the blood and intercellular space. The normal calcium level, if we talk about that, is 2.1 to 2.6 millimoles if we talk about the millimoles, and if we talk about the milligram per deciliter, that is somewhere between 8.5 to 10.5. Okay, now let's talk about the regulation of this calcium, okay, the metabolism. Now you know that the calcium is regulated by the two things. One is PTH. Whenever there's a decreased calcium, okay, it is regulated by the two things. It's a PTH, and the other thing is active form of vitamin D. So what does they do? If there's a decreased calcium, there's an increased PTH secretion that leads to the calcium being drawn from the bones. So it draws the calcium from the bones to the blood. And what does vitamin D do? It increases the calcium absorption from the intestine, and at the same time it decreases its excretion from the kidneys. Okay, now this calcium, okay, this is present, the total serum calcium, if we talk about, okay, it's in the two forms. It is one is that is bound to the albumin, and the other is free ionized form, which is physiologically active form. That's why we always calculate the corrected calcium, because that's going to give us the good estimate of what the real calcium is, because this free calcium, this is the physiologically active, while that bind to the albumin, okay, that's the other form that's not readily available until unless it's freely ionized. Now there are certain things, okay, which can give high calcium level. Like if you have high albumin, that's going to give a high calcium level. That's why we have to calculate the corrected calcium. Now the next thing is we are going to talk about the symptoms of the hypercalcemia. So hypercalcemia leads to the kidney stones. Okay, you remember that, okay, hyperparathyroidism that leads to kidney stones, the bone pain, abdominal moans. You remember that, I hope. Muscle tones, psychiatric overtones, okay, thrones, they're all the things which were in a rhythm. So it causes actually the kidney stones, the bone pain, abdominal pain, constipation, muscle weakness, depression, cognitive impairment, and you know that in the ECG it also does something with the heart as well. It causes the short QT interval. Actually, what happens over here is that the calcium, okay, it acts as a sodium channel blocker. Okay, it acts as a sodium channel blocker. So when there will be the excess calcium, so it's going to block the sodium channels, and it wouldn't let the sodium to go inside, and we know that the sodium is important for the action potential. So what's going to happen? There will be no action potential. Okay, they're going to depress the sodium channels, so there will be decreased neuronal excitability, confusion, lethargy, as well as the muscle weakness over there. So these are the symptoms of the hypercalcemia, and the heart is going to cause arrhythmia and the the short QT interval. Next thing is that what causes the hypercalcemia. So first thing is hyperparathyroidism. Okay, and that's the most important and most common cause of the hypercalcemia. So that could be either an adenoma, okay, or simple hyperplasia of the parathyroid gland, or there could be something more serious, okay, the malignant thing over here. So this increased PTH, okay, due to either benign or the malignant growth. The second common cause is the cancer. So how does the cancer increase the calcium? It increases by the two mechanisms. One is certain cancers like the squamous cell carcinoma of the lungs, you know that it releases the parathyroid hormone related proteins that acts like a parathyroid hormone, and it draws the calcium out of the bones into the blood, causing the hypercalcemia. Well, the difference of this parathyroid related protein to the normal parathyroid hormone is that it is not subjected to the negative feedback. You know that a normal parathyroid hormone is subjected to negative feedback. That's a low calcium leads to parathyroid release, and once the calcium is up, the parathyroid hormone secretion is decreased. But this parathyroid related protein is not subjected to this negative feedback mechanism. And the second thing how it's going to do is the cancers, okay, either the primary bone cancer or the mets, they cause the bone reabsorption, and that leads to increased calcium in the blood. Then increased vitamin D, okay, maybe somebody is taking in the form of tablets that can cause hypercalcemia. Then Paget's disease, you know that there's a high bone turnover in the Paget's disease that leads to hypercalcemia. Then the drugs, particularly these thiazide diuretics, they cause the hypercalcemia. And lastly, the renal failure as well that causes hypercalcemia. So these are the causes. Now let's talk about the labs. So you know that you need corrected calcium level. The other things you can do is the ALP and the phosphate. You can do the X-rays, okay, and the skull X-ray in hypercalcemia is a chronic one that you can see a salt and pepper appearance, okay. You can do the ECG and you're gonna find over there the long QT. You can do the scans as well, okay, particularly in those cancers. You know that you do the parathyroid scan, that is system EB scan to find out. So that's all the things there. These are related. You can do the vitamin D levels as well. So depending upon the cause, okay, you have to do certain investigations to rule out that. So now at the end, coming to the treatment. So if it's a symptomatic hypercalcemia, or if the levels are greater than 12, okay, you need to give the patient's fluid, okay. That's how you're going to help the patient to excrete the calcium, high calcium levels. You can use the diuretics, okay, that is the loop diuretics. We knew that the thiazide diuretic, they increase the calcium level, but these loop diuretics, they help, but you don't use them in all the patients. You use them in the patients where there is a risk of fluid overload, particularly the patient with the heart failure, because you are giving the fluids. Now you can do the surgeries like for adenoma and the cancer. In some patients, you can use the bisphosphonates. You know, we know that the bisphosphonates is inhibit the osteoclastic bone reabsorption, and in a few patients, you may use the calcitonin. The calcitonin inhibits the bone osteoclastic activity. So these are the treatment options available here.